for that introduction. And I welcome each one of you for this session. It will be a long session initially, but I'm sure we will be having a good discussion later with the case presentation and your questions and whatever clarifications that I would be happy to help with. And thank you very much for joining. And can I screen share, Hashmat?
Yes, ma'am. Please go ahead.
Thank you. Yeah. Is my screen visible?
Yes, ma'am. A web page is visible. Google Chrome.
Oh, not the screen? Oh, God. Okay.
Yeah, the screen is visible, but it is a web page.
Now?
Just a
For that, but I guess technology and me are a challenge. So just for an overview, the session today, because I'm a palliative care physician and all of you are pulmonologists, so your strength is your field, and I'm sure you all are excellent pulmonologists. So the whole idea of this session is to introduce you to the symptoms, which are the non-respiratory symptoms that you see, and how we as palliative care physicians work with these symptoms. The reason that we are in this together is that we all understand that chronic respiratory disease is the symptoms here are chronic symptoms. So whatever I'm discussing today is in the context of chronic disease. So that is the reason why we need to integrate together. And so the symptoms that I'm going to touch upon are fatigue, insomnia, anxiety, and depression. So to start with fatigue, when we want to define fatigue, we know that how difficult and how complex the system is. It is a debilitating symptom. It impacts the physical, the functional, and all the psychological domains also. So it's not just physical fatigue, but it is also physical and mental fatigue. And why is this symptom difficult? Because it's complex. It has so many factors which contribute to it. It is unstable, it is dynamic, and most importantly, it is subjective. And that is why it remains underdiagnosed and undertreated. And cancer-related fatigue is a topic of its own because it's persistent. And again, it's very subjective. And there is physical, there is emotional, there is cognitive tiredness. And many times it's not proportional to the activities of the patient. And that is why it leads not just to patient distress, it leads to a lot of caregiver distress too. So what contributes to fatigue? We think most of the time that it's cachexia, which contributes to fatigue. But we do see patients who are well-built, who look well-nourished, and they still have phenomenal fatigue. So it's not just the cachexia, which is a contributor, but there are conditions like the anemia, infections, comorbidities, dehydration, deconditioning, all of these which are contributors to fatigue. Regarding cancer-related fatigue, of course, the symptoms, the polypharmacy, the disease by itself, the therapies, all of that can contribute to fatigue. So when we talk about respiratory fatigue, there is something called as perceived fatigability and performance fatigability. So to understand why fatigue is important, to understand why we need to assess and address this symptom, it just helps to know that perceived fatigability is a trait and it's also a state. So you can have this at rest or you can have it in physical activity. And performance fatigue is what happens during physical activity. Why is it important to understand this? Because the perceived fatigability depends on the psychosocial state. It depends on the mood. It depends on the expectations, the motivation of the patient, the other symptoms that they have. And it also depends on body homeostasis. So what is the core temperature? What is the blood glucose? What are the parameters? All of that. And when you have performance fatigability, That is muscle related and the central factors related. So when you're doing a particular activity, I'm cycling, I'm doing my 6-minute walk, how much fatigue am I having? So it is all of these factors that go together in causing fatigue. And how do we see it? The consequences is what we see. So the controlling factors are what is happening within the body. The consequences are what we see, and that is what we see over here, with the consequences we see in the cognitive function, in the motor function, and in the psychological well-being. So now, what this is visible to us, this is what is happening in our body. What are the modulating factors that we can have? We also have what is the kind of respiratory disease this patient has. Is this a male? Is this a female? What are the normal tasks that they do? What is the environment? What is the precipitating factor? So understanding this helps us in designing the interventions. So is there any way we can bring down the performance fatigability? Is there any way that we can bring down the perceived fatigability? Is there any way we can increase the exercise and rehab efficiency of this patient? These are the things that we are trying to do. So when we talk about fatigue and chronic respiratory disease, besides perceived and performance fatigability, there is again a very important factor, which is the patient demands and the patient capacity. In the beginning of the treatment, the patients are really responsive because they have the disease has just been diagnosed. They are willing to do everything that you tell them. They are willing to fight it. All of those things they're willing to do. But this does not change. This does not change overnight. It's a chronic disease. So over a period of time, what starts happening is that the general demands increase, the disease is progressing, the treatment demands also increase. We tell the patients, you should go to rehab, you should be able to do this. They have to run their own lives. The caregivers have to do their own thing. So as the demands increase, the patient's capacity slowly starts decreasing. So those resources are now depleting. The illness burden is increasing. And what happens is fatigue increases, gradually adherence to treatment decreases. So that is why fatigue is such an important symptom, because we need to evaluate fatigue not just at one point in time. We need to have a regular longitudinal assessment. And when we do that at various timelines in various contexts, we actually understand the patient. We can help intervene better. So when we talk about assessment of fatigue, that is why the evaluation of the severity, the duration, how it interferes with daily life, and what kind of problems fatigue is associated with, the psychological and social, is very, very important to us. And you do the 6-minute walk test. We also ask about task-related fatigue, which we find is a very useful way to take the history. You were doing this. What is it that you used to do? What is it that you cannot do now? We do have assessment tools, the visual analog, the numerical rating scales. We also have the performance status, which I'm sure you do it at every visit, which we also do religiously at every visit. So what happens is when we evaluate and when we assess longitudinally, we are able to evaluate better. And in the evaluation, it is not just, are you feeling tired? How often do you feel tired? Do your 6-minute walk test. What is happening around? We also are definitely conscious about the disease and the treatment. So what trajectory of the illness is this patient in? Is it active disease? Have they finished treatment? Is this fatigue towards end of life? Has the disease recurred and now is there fatigue? Is the disease progressing? What kind of therapy am I giving the patient? How is this patient responding to my therapy? Along with all the other factors, we have to take the disease and the treatment also into consideration. So that is why now, having done all of this as part of your assessment, it is still a challenge to manage fatigue. And why is it like that? Because the pathogenesis is ambiguous. You can have so many mechanisms. It is so multifaceted and dynamic. You can have fatigue on one day, the next time the patient says you're feeling better. There is also patient factors. Which patient would like to tell their doctor, I'm feeling tired, as a symptom? It doesn't come out very easily because they are already overwhelmed with the disease burden. They are trying to figure out what is going on. And unless they have a really strong relationship, which is built over a period of time, it is hard for the patient to actually sit and discuss tiredness with the doctor. At the most, they may say, I'm feeling tired, but they also are scared Because what if being tired is my fault and the doctor does not give me aggressive treatment? Then I cannot get cured. So these are the kind of thoughts that go on in the patient's mind. And they feel that when you have such a disease, fatigue is going to be inevitable. And from the physician factors, many of us know, what am I going to do if the patient tells me I'm feeling tired? I don't have a drug to offer the patient. I can't really tell them this is what you're supposed to do and it's going to work like magic. So there is an element of clinical inertia. And we ourselves have gaps in knowledge. And also that subject, it is such a subjective symptom that it makes it difficult from all perspectives. So at least if we start by assessing our patient, being able to evaluate that fatigue, and what are the general management strategies that we can do. So for the patient and caregiver, they need to feel empowered to talk to us about fatigue. We need to educate them about the level of expected fatigue, how they are going to balance their activities, how they are going to rest, not rest all the time, but balancing activities and rest, and how they are going to cope with all the things that are happening around. From the physician's side, if we start by acknowledging the symptom, by identifying the triggers and giving them anticipatory guidance with a proactive approach, and do all of this with our multidisciplinary team, that is when we start with general management strategies, from treating fatigue to managing fatigue. So in general, we have we have a system in the hospital, because cancer-related fatigue is so common. And so what are the things that we tell patients? How do we educate them? How do we pace activities? How do we delegate? And then how do we combine both non-pharmacologic and pharmacologic interventions? Because as each one of you is aware, the management of fatigue rests on non-pharmacological interventions, because that is the first step for management of fatigue. And so how do we talk to the patients? How do we tell them to pace activity? How do we tell them to use walking aids? How do we tell them to deal with causes? So how do we address the anemia? How do we tell them to conserve energy? How do we manage effective symptom control? We manage the breathlessness well, we manage the pain well, automatically the fatigue comes down. And also, if it is early fatigue in the treatment, how do we manage? But at end of life, how are we going to manage fatigue? So all of this is what we gradually think about and do it. At end of life, the maximum focus is on conserving energy, very good symptom control, optimizing whatever symptoms that we have, we try and treat them aggressively. We also decrease polypharmacy, and we tell them to rest. Whereas early fatigue, we manage differently. We give them activity, we give them pacing, we give them aids, we do all of that. So in the management, again, I reiterate that it is a non-pharmacological, which is very, very important. And pharmacological, we use corticosteroids in cancer-related fatigue. We do use it in our setup. Megestrol is also used, that is used as part of chemotherapy also, but we do give megestrol. And so, but these are only if we absolutely need it. Corticosteroids we still use, but most often we try the non-pharmacological, and we begin with education and counseling and supporting the patient and caregiver right from the beginning. So from fatigue, we come to our next symptom, which I'm going to touch on, which is insomnia. Now, insomnia is difficulty in initiating or maintaining sleep. All of us are aware of this, and you as pulmonologists specialize in sleep disorders. So the insomnia that I'm going to deal with here is just as a symptom associated with chronic respiratory disease. So you can feel daytime tiredness, you can have fatigue associated with it. And when we call it insomnia, we say that this disturbance should be there for at least 3 nights in every week, and it should persist for about 3 months with night-to-night variability. So you are well aware that there are plenty of comorbidities and risk factors with insomnia. Many of them we contribute, because many of our medications are also cause insomnia. There is also prescription medications. There's also non-illicit substances. You can have a psychiatric disorder. You can have a sleep disorder, which causes the insomnia. You can have your respiratory disorder. You can have cardiovascular, neurological. Also, the shift hours, the lifestyle, these are all contributors and comorbidities that they have. So when we classify sleep disorders, there are plenty. But what we are trying to talk about is only insomnia as a symptom. How do we address it? So we know that there is a perturbed respiratory system. The patient is getting up, they are coughing, they are hypoxic, they are with oxygen. There is a level of sadness. There is so much anxiety because I am tied to this oxygen all the time. If I step two, if I take 2 steps, I'm going to become breathless. And in cancers, it's also the effect of the therapy and the drugs that they take and the medications that they take. So all in all, insomnia can be very, very troublesome. So whenever we take a history, there are a few things that we ask. Are you finding it difficult to initiate sleep? Are you finding it difficult to maintain sleep? Or are you able to sleep, but do you wake up early? Or do you have snoring or excessive daytime sleepiness? So we try and identify what is the primary complaint. And then we try and characterize the complaint with its onset, severity, how long it's been. We also ask about anxiety and thoughts to the patient. Is that what's keeping you awake? And we also have to document all of this schedule and find out what is the patient's expectation from us, what are the distortions they have. So we ask them, what is it that you think about? They tell us, many times they just say that we know that we are not going to sleep. So that kind of catastrophization, that definitely requires behavioral therapy. There are also tools, and we try and find out what predisposes to this insomnia, what is precipitating it, and what is perpetuating it. Many times patients are taking their diuretics in the night because they just don't realize that they are doing that. Many times they are diabetics. They have to get up 10 times to go to the washroom in the evening. Our patients have ileostomies, which again means that they have to clear out their bags so many times. So the causes for insomnia can be very many. Unless we sit down and ask them, what causes this? How many times do you get up? Is it the pain that's waking you up? Is it the thought? Is it the breathlessness? What kind of schedule do you have? Do you sleep in the morning? And you're awake all night. Is that the cause? So when we come to the therapy for insomnia, it is based on the 3 Ps: what predisposes, what precipitates, and what perpetuates. And here again, the evidence is for chronic cognitive behavioral therapy for insomnia. So that does have the highest evidence. As far as drug therapy and pharmacotherapy goes, you can use the GABA agonists, the melatonin, which can induce sleep. And then you have your DORA group of drugs or your monoamine inhibitors. All of these can decrease the wakefulness and induce sleep. But before we go to pharmacotherapy, there is a huge role for cognitive behavioral therapy. So this is one of the algorithms in chronic lung disease, where again, they say that once you do have insomnia, try cognitive behavioral therapy first. If that is working and effective, just stay there and continue with it. Only if it doesn't work, then of course you all are going to do your pulmonary function tests and all your other tests, and then you can add a drug to it. Cognitive behavioral therapy, there are 2 parts to it. So what we can do as pulmonologists, as palliative care physicians, when somebody is unable to sleep, is use the behavioral strategies, because the cognitive strategies are highly specific. For that, you need psychoeducation, and that is usually done by psychologists. But what we can do as behavioral strategies is teach them sleep hygiene, teach them relaxation, do things to facilitate the circadian rhythm, try stimulus control, and also sleep restriction. Sleep restriction, of course, doesn't mean you restrict sleep. It just means that the area where you sleep, you restrict it only to sleeping. So you try these behavioral strategies first and try and bring down the causes because of which the patient is not sleeping. So if pain is a contributor, if they have to go to the washroom so many times is a contributor, if breathlessness is a contributor, let's try and bring down all those symptoms so that once that is done, anxiety comes down and automatically the patient is able to sleep, and add sleep hygiene to it. So this is what we use most of the time. And as far as drug therapy goes, we very rarely use drugs to induce sleep, at least in palliative medicine. What we do is the use of off-label drugs. So if my patient has neuropathic pain, I will put him on amitriptyline or a gabapentin or a pregabalin, which will automatically also induce sleep. And then if my patient has very severe nausea, vomiting, loss of appetite, things like that. And on chemotherapy, I would give him olanzapine at night. And that would also enable him to sleep. Suppose your patient has, say, a bad itch, a bad cough. I could always try gabapentin then. I could use mirtazapine when the patient has insomnia, when the patient feels breathless, has an element of neuropathic pain, because mirtazapine is again a beautiful drug. It can be used for many causes and also induces sleep. So in the practice of palliative medicine, that is what we do. We try to use one drug and address more symptoms with that drug. And many of these medications, almost all of these medications are sleep-inducing. So along with good sleep hygiene, along with a good assessment and history, some amount of counseling, and the use of drugs to bring down the symptoms, we come close to managing our patients and doing well without having to actually put them on any of these medications. So another thing in pharmacotherapy, what we need is to restrict the corticosteroids and diuretics to the morning dosing. Many of our patients, especially those of whom are on corticosteroids, they take it in the night. It upsets the circadian rhythm. So we usually give it in the morning. And then we can use melatonin in the elderly. And if there is a depressive disorder, you can prefer a sedating antidepressant. So trying to give them a drug for another symptom, which also can induce sleep, helps very, very often. So we also say choose wisely, because especially in our practice, along with morphine, we do not use benzodiazepines or other sedative hypnotics as first choice, especially if our patients are already on morphine, we usually avoid it. And of course, at end of life, it's different. And so whatever we use, we need to use with caution. We need to use and evaluate regularly. And we should be mindful that these medications can cause dizziness, daytime sedation, nocturnal confusion, and falls. So we have to keep all of this in mind. So we have to document it and also tell the caregiver and relative that if we are starting these medications, this is what can happen. Tell them to leave the washroom door closed. Don't tell them to leave it closed, let them leave it open. If they're getting up in the night, make sure that there's someone around, keep a bell near them. So these are little things that we tell them, but very, very useful so that they do not have falls. Mirtazapine, like I told you, is again a good drug that we use. We use it for pain, sleep disorders, anxiety, nausea, vomiting, and breathlessness. There's another recent article, even after this article, which is pretty recent, on the use of mirtazapine for multiple symptomatology. Now, fatigue and insomnia, the last part of today's session is also a bit on psychological disorders. Psychological disorders is again very, very important, because why should we identify psychological distress? It is the core to so many things. It is central to pain. It is central to breathlessness, because we are all aware of the breathing, thinking, and functioning model. So it's not just the breathing when it's affected that causes breathlessness, it's the thinking and the functioning. And so that is why we need to identify psychological distress, because it absolutely erodes quality of life and it amplifies all the other symptoms. It causes so much anguish. It's a risk factor for suicide. So if we build trust, if we start talking to our patients, understanding their illness experience, it is very, very useful. And why is there so much psychological morbidity? Because imagine a patient with respiratory disease. He is going to have functional limitations. He's going to have pain. He's going to have weakness. In cancer, they're going to have the anorexia cachexia syndrome. So all of this is going to contribute to his psychological morbidity. Because when each of these factors are considered separately, that's bad enough, but many times they have a combination of all of this. And it's not just the person. When we look at the person sitting in front of us who has come to us with a complaint, it is not just how is that person feeling, but we have to take one step back, because he may be coming from a home with a very difficult history there. He may be having people at home with psychiatric history, or we don't know whether there is violence or dysfunction or abuse in that family. We don't know whether there is a background of unresolved grief. All this in addition to the disease that he has. So the person we are seeing in front of us is coming from a background with we do not know what factors contributing to his psychological morbidity. There could be substance abuse. There could be so many things. And even if these things do not exist, the person sitting in front of you could be so distressed that why is this happening to me? I was working, I was living a regular life. Now this disease has taken away what I like the most. I'm not the person that I was. And then we put them on medications. And our medications again cause distress. They cause so many, in so many ways, our medications trouble our patients. Chemotherapeutic agents, they can cause hair loss. They make you so tired. They just take away the person who you were. Our opioids, so many others. And then after that, sometimes our patients have to be on oxygen all the time. So they are dependent on machinery. So when we look at the numerous things that they have to deal with, it's all okay if we are dealing with an acute condition. If I have to do this for 1 month in my life, I will do it. I will even do it smilingly. But if this is going to become my life, if this is going to be how I am going to live all the time, it can cause immense sadness. And it is not just the poor who are sad and who have psychological morbidity. Many times it is also those who are well-to-do. And I'm sure you in your practice will be seeing a lot of these patients. They may be living in high-rise buildings. They may not have access to elevators at some points. They may be living, in a building without a lift. All the children might be abroad. And then the children from abroad give them a set of instructions on what to do. And they are alone. They do not have a great support system. And because of all of this, there is immense psychological morbidity. So when we talk about anxiety and depression, we cannot use these terms loosely because these are very clinical terms. And psychiatric illness is often underdiagnosed, undertreated, and almost remains untreated also. And many times we don't recognize it, but it is a diagnosis of exclusion. So you must be able to take a history to assess that the symptoms are causing significant distress to qualify as a disorder. So why do I say that? Because you have a spectrum here. You have something called a major depressive disorder. You have something called a generalized anxiety disorder. But all our patients don't fit into these categories, nor are we supposed to box them into these categories. That is because most of our patients have anxiety or depressive disorders. They could even have it secondary to medical causes. But besides that, the large chunk of the patients that we see have what we call as adjustment disorders. Now, when I say adjustment disorders, what do I mean by that? In this spectrum, now suppose I have a stressor. Suppose I have been dealt with this diagnosis. You have ILD is the diagnosis that has been told to me, or you have COPD is what has been told to me. Immediately, what happens to me is first a sense of shock, a sense of grief as to why is this happening to me? And you have now told me that this is chronic. I'm not going to be able to cure you, but we will be able to control your symptoms. Or we hand out a cancer diagnosis and tell them the same thing. We are not going to cure you. We will try our best to control. So this information is going to take time to process. So anyone who's been dealt with this diagnosis is going to take time. So that is why it takes anything from 3 to 6 months to process this information. So at that time, the patient will go through all of these stages. He will cry. He may cry. He may go into shock. He may be grieving. He may be bargaining. He may be upset. But that doesn't qualify as depression. So first, we give them time to adjust. And even after 6 months, these things are not happening. He is still not coming to terms with his diagnosis. We have to start thinking deeper. We have to start asking questions. We have to find out and explore his concerns. So usually an adjustment disorder lasts less than 6 months. And you can have moods, but they will fluctuate. It's not going to be there all the time. But when we talk, and so you can have anxiety at some time, you can have sadness at the other time, you can have anger, you can have, different behavior, all of those things you expect. But it doesn't stay with you the entire day or the entire time. But even after 3 to 6 months, if these symptoms are going to persist, and what you see is constant, this patient is constantly worrying, unable to concentrate, they catastrophize, they cannot turn out their thoughts. you have to be cautious. And suppose this patient is crying all the time, is losing interest in what they did, it has fatigue all the time, there is change in appetite, there's change in sleep, then you have to start thinking again. So that is why we need to understand the patients. So before we go into exploration of psychosocial distress, the first thing that we do is explore their understanding of the disease. Because the first step is that, what do I have? That is something they need to understand. And then take away all the factors that are reversible. What you can reverse, please do it. So if there is hypoxia, sepsis, if there is infection, anemia, try and reverse those factors. The challenges will always be the symptom cluster overlap, which we will come to in the end. And what are the helpful questions? So now all of us are not trained psychologists. We are not trained psychiatrists. But what can we do at a screening level? There are a few questions that are very helpful and what we can ask at a screening level. So when we screen for depression, the questions that we usually ask is, during the last month, do you feel sad or very sad or helpless most of the time? If the answer to that is yes, the next question is, and even if the answer to that is not yes, the next question is also important, is during the last month, have you been bothered by lack of interest or pleasure in doing things? So the easy way to ask these questions is, what has your routine been? Has it changed now? Are you doing the things that you once did and which gave you pleasure and happiness? I don't feel like doing anything now. I just lie down all the time. I cry most of the time. I just feel very sad. All of these are red flag signs. And then if the answers to these two are yes, you have to sensitively ask, do you feel about the risk of self-harm? Have you ever felt like harming yourself? Do you ever feel that life is not worth living? So those are the kind of questions that we use to screen for depression. When we talk about anxiety, we usually ask them, are you worrying all the time? Have you been crying? Have you been finding it difficult to concentrate? Do thoughts constantly come and trouble you in your mind? And most important question is, are all these changes affecting your daily routine? Okay, this comes for a small amount of time. I think about it, and then I tell myself I have to live with this and then go along my day. That is a good sign. You're coping. But if these thoughts are bringing you down, they're plaguing you down, and then when these are your screening questions and you find this happening almost all day, that is when your red flag signs. These are red flag signs. You need a referral to a psychiatrist. So the PHQ questionnaire, again, comprises of these questions. So this is, again, a simple scale that you can use in your clinic, or you can use the screening sections. So what's important is gently assessing this part and screening the patients so that if you feel that they need help, you can immediately refer. Otherwise, at your level, you can counsel, at our level rather, because even we do that and refer to counselors or psychiatrists if we think that the symptoms are in the moderate to severe category. And when we have to manage depression, again, most of the things that I am covering today, all of these, the non-pharmacological reigns supreme. So again, in the management of depression, it is the non-pharmacological psychotherapeutic interventions, the social support, the family interventions, which are very, very, very important. And again, we have a wide group of drugs here. You can have the tricyclics, you can have the SSRIs, the SNRIs, and then you can have psychostimulants. All of these can help with antidepressants. So this is another algorithm or a decision tree that you call it for pharmacological management of depression. So you look, usually this is in the palliative care setting, you look at the prognosis. If it's less than 6 months, you can try psychostimulants. We don't usually use methylphenidate. We just use the steroid because that itself can kind of be uplifting and help. That's a very short course or a pulse course of steroid. But this is the evidence. You can use methylphenidate. And if the prognosis is over 6 months, you choose your antidepressants. You choose which one you want to take. You start it at 1/4 or half the dose and then gently increase the dose. Once you've come to a dose where you see full remission, you can continue it. If there is no response, you might have to change the drug. Again, for us, the principle is the same. When we choose the antidepressant in palliative medicine, again, if the patient has pain, I can choose a tricyclic because that will help him with the pain. It will also help with this. You can use mirtazapine again. Again, it has a nice antidepressant role. It is also sedating at lower doses. So the drugs that we use most commonly are the tricyclics, mirtazapine. We do use fluoxetine at times when we really need help for the patient, but usually along with a psychiatrist. So few more questions that we ask before we start the patient on antidepressants are, has this patient used them before? Have they responded well to a particular medication? And if the answer to that is yes, it is worth starting with the same drug. When we talk about anxiety, again, like I already mentioned, it can coexist with adjustment disorders, but in the assessment, we have to include the history. And most importantly, we can't stop with just asking the patient. We also have to ask the caregivers, because discussions with the family, the carers are also important, because they are the ones who are living with the patient and who will be able to give you better insights. And in the non-pharmacological interventions for anxiety, you have plenty. You have everything from music therapy to aromatherapy to managing and living meaningfully, supportive psychotherapy. So these kind of therapies are usually done by the psychologist. At our level, what we usually tell the patient is that you feel worried all day, keep an hour a day to worry, and keep a little comfort bag. Keep things that you like and which give you comfort in that bag. Have a little bit of visual imagery. Think of the times that you had good times, and keep 1 hour in a day when you can worry, but can you try not worrying the remaining time? So these are little ways in which we start, because I know that most of us in our practice don't have the luxury of having the availability of a psychologist all the time for all your patients. So that's almost impossible. That will become fragmenting care. So a little bit is what we start with. We assess. We give them medications which can support more than one symptom. We give them small tips on how they can manage their symptoms. But if we feel that they are not doing well, an immediate referral becomes important. Among the various medications that we have, the benzodiazepines can help in a panic attack. And so we choose the benzodiazepine. Suppose you need a longer acting, or during the dying process, we usually choose midazolam. If there is a panic attack, we go by that is where we use benzodiazepines as first line. Otherwise, you can use the SSRIs, and you can also use the other antidepressants, like I told you, mirtazapine. When there is comorbid insomnia, when there is comorbid pain, you can use duloxetine. So these are the various medications that we use. We also use clonazepam along with, if the patient has pain, we can give clonazepam if he's anxious. If there is anxiety and pain, or neuropathic pain, we can also choose pregabalin. So every drug that we use, we try and see if more than one symptom is addressed. So that brings us to what we call as symptom clusters. Like what you saw, there's something called symptom clusters that we see in chronic disease all the time. And it's really interesting because fatigue is usually associated with pain, with depression, and a sleep disturbance cluster. So imagine if you can bring the pain down nicely, and if you can address the fatigue with non-pharmacological techniques. That non-pharmacological interventions will keep the patient awake during the day, will help the patient sleep at night. So with one simple medication, with a good assessment, you can actually treat an entire cluster. So in lung cancer, pain, depression, and fatigue is a cluster that they see. In COPD patients, you see general somatic distress, fear, nervousness. There are respiration-related distress. There is anxiety symptom clusters. So if we are able to identify symptom clusters in these patients, if we use a good tool to go through the symptoms, so we usually use the Edmonton Symptom Assessment Scale, which has 11 symptoms, which we grade at every visit. So we use the scale, we pick the symptoms, we address these symptoms, and try and bring this cluster down. So there are different reviews which have symptom clusters in COPD. Any of you all in respiratory medicine could take this as one of your research topics or audit topics and work on that. And you could even do collaborative research on this, because there is a lot of scope to do this. Why are we doing all this? Why are we even having these sessions together? Why are we pulmonologists and palliative care physicians meeting and doing all of this together? That's because we believe that in the interest of our patient, we should be integrating care. And when we talk about integrating care, all of these are models for integration in respiratory disease or in non-malignant disease, and this one is specific for chronic respiratory disease. So what they say is at level 1, the patient will need specialist respiratory care. When the patient is diagnosed, when you're treating, he's going to need all of you specialists and a bit of generalist palliative care, which you can definitely provide if you are aware of what palliative care is and what we do. So these sessions will help you in providing level 1 generalist palliative care comfortably. And so generally, even level 1 and level 2. But suppose the needs become more complex. Suppose right from information needs to symptom needs, all of this becomes complex, then dealing with all of them by one person can be a challenge, especially when we look at a trajectory that is lifelong. So that is one where level 2 and level 3. So as the complexity of the symptoms and needs increase, we will integrate more. So we start with generalist palliative care and specialist respiratory care, and slowly move to specialist respiratory, specialist palliative care, and level 3 might include even generalist palliative care. So as you go up, you need to add more levels to this as the complexities increase. And when we look at disease trajectories, this is in COPD. So you can also identify triggers. You're working in an institute. So you have palliative care physician, you have yourself, you have an ICU, you have all of you can integrate together. You can identify triggers. You could say that if there are troublesome symptoms, or if there are unmet caregiver needs, if there is a risk for multiple hospitalization, impending respiratory failure, I'm not able to talk to this family. If there is too many, say 3 hospitalizations in a span of 2 months, you are seeing functionality coming down. All of these become automatic triggers and indicators for palliative care integration. So you can develop symptom integrated triggers. You can have short-term palliative care, like a bit of them, and they maybe then you continue and again bring them in when needed. You can have integrated respiratory care services. So the rehab, the discharges, the home part is managed by them. You manage them when they come here. So there are various models. Palliative care can be a very creative field. And depending on the colleagues you have, the institute that you work in, the support system that you have, you can actually create models for integration. And this is again an important slide. This all along we talk about what you would like to do and what I would like to do. What I would like to do as a palliative care physician, what you would like to do as a pulmonologist. But the core of healthcare is what is it that the patient wants? So that is why all our care needs to be personalized, because it's like a jigsaw puzzle. I can't just put in what I want to do into everyone's care plan. My care plan has to be designed for that particular patient, and that's the core of shared decision making. And that is why it is important to understand the lived experience of patients. So that's what this article brings out, the lived experiences of the patient. It tells us about what are the symptom burden, what is the psychosocial effect, what happens to the caregiver, and to deal with all of this, a single you or a single me is not possible. We need a multidisciplinary team. But having said that, okay, I need a physiotherapist, I need rehab, I need counselor, I need nurse, I need doctor, I need respiratory physician, I need palliative care. Having said all that, the core of integration is that we should not fragment care. So I can't tell my patient now, go and meet this person, meet this person, meet this person, and come back. It has to somehow fit in together. So we should be able to integrate without fragmenting care. So that is why team building, how we work together, being informed about what the other person has done, all of this is also an important part of chronic disease management. So this is another model. This is for ILD patients with ILD and their needs. So this figure nicely tells us what are the needs of these patients. They need education, they need, the families need reassurance, they have mobility issues, they need symptom control, they need oxygen, they need medications, and then they need to understand where they are in the trajectory. They also need good end-of-life care, and adequate information. So this figure tells us that they need so many things. So it's difficult for one person to do it all. So that is why we work as teams and we try and integrate all of this. So this is again another flow chart where it tells us that when you have a diagnosis, what is its impact? Early, what is its impact? If there is a good outcome, then how do you integrate palliative care? If you really need the conversation immediately, then how do you integrate palliative care? And again, this is another very nice algorithm which says the ABCDE of care. So how we need to assess, how we need to back up our patients with good education, self-management, support groups. How do we provide comfort care? How do we deal with disease-modifying treatment? And how do we deal with end-of-life care? So in our care plan, if we include the patient, the caregiver, assess, provide comfort care along with disease-modifying treatment, and have a nice roadmap for how this course is going to go. How can I provide end-of-life care? Then that is the ideal world. And I think that is what we would want if any of us had any of these diseases. So a care plan is very, very important. And that is where we need to keep everything in mind: the pathology, the physiology, the psychosocial factors, the pharmacology, the prognostication, the pharmacoeconomics. And the core to all this is, of course, the practice of medical ethics, because each one of us are aware that we should do no harm. So team building is something which build on your strengths, lead by example. We all need generosity of spirit to network. You all are excellent in your field, and pulmonology is your strength. Medications are your strength. Maybe there are soft skills that the palliative care team can provide with it, and together we can make a difference. So thank you so much for your very patient hearing. And I am ready to take on any questions. I hope that's okay, Mr. Krishna and the team from Pallium. So I'll just stop sharing here. All the references are there on the slides, and I'll be sharing it. So you're free to keep them. I've just put in all the references towards the end. So there is quite a bit of reading that you can do.
Thank you so much, ma'am, for such a wonderful session. And you have stressed a lot on the non-pharmacological aspects. That was really, really great. And if participants, if you have any questions, you can post in the chat box, or else you can even, unmute and ask by raising your hand first. So that's how we'll go about. Maybe for another 5 minutes, we can take questions and then move with the case presentation, ma'am.
Please feel free to share your questions or even your experiences, because like what are the challenges that you face? Because I'm sure each one has their own challenge. It could be a challenge with setting or the disease. So please feel free to ask.
Can I
Yeah, sure.
speak something?
Yeah.
Yeah. In fatigue, there's another point is that sometimes we check for the nutritional deficiencies also, because sometimes the hemoglobin is low, and we try to do that iron profile and B12 and folate. And I've seen in a lot of all these patients, they have very low iron reserve. So sometimes giving an IV iron in these cases helps.
No. Yes.
Not always,
Definitely.
sometimes. Yes.
Yeah, definitely. It was, I did not stress on it. It's there in the first part of those slides with all the correctables, which include anemia, infections, nutrition, low iron, all of this. B12, plenty. You're absolutely right. And that is why first we try and deal with the reversible causes, what can be reversed. But again, Sonali, I'm glad that you brought that up, because when we talk about reversible factors, now this fatigue, if we see early in the course of the disease, then it's nice to treat it. But suppose you have a patient at end of life, and at that time, if you're going to be doing all the labs and sitting and correcting the reports, then there is an ethical dilemma to that, because how far should we go? And are we only correcting reports? And so what you said is very, very valid in early and concurrent therapy. But when patients are absolutely towards end of life and their prognostication is in days, at that time, usually we avoid doing tests even, because even that becomes a challenge.
Yeah, true. But we don't try not to intervene much.
Interfere much at that point in time. I can see a couple of questions from Madhuri. Most patients get offended if a psychologist, psychiatrist advice is offered, considering the stigma around it. How do we go about it? That is a very good question. Does anyone else have this experience?
Yeah,
Ma'am,
I have the same experience.
yes.
I too felt so.
Okay. So I'm only asking this because at least in a setup with cancer, because I work in a cancer hospital, so usually a psychology referral is just part of the referral. So we do not really treat it like a stigma. But having said that, I'm sure many patients do feel like going to them. So that is where I think if you have a chart in your room with the breathing, thinking, functioning model, it might help. If you have a patient who is coming to you and you tell them that, you know, your breathlessness is happening because your lungs, that part I'm going to deal with. And there is something called functional. So breathing, thinking, and functional. So the functional part, that is where I'm going to give you my rehabilitation specialist or my physiotherapist referral and the thinking. So because all these areas are related, for the thinking part, I plan to send you to our psychologist. I don't know if that would work, because that is scientific, it is evidence. And if you can tell them, like, you know, you can use the BTF model, you can keep it on your table and tell them, this is why I'm sending you, because they are going to equip you with skills. So usually when I send them to psychologists, I tell them they are going to give you some exercises. Like how I'm giving you exercises for the hands and for the legs, they are going to give you exercises for the mind. So that's the word we usually use, and it has been helpful because there is no negative connotation in an exercise. And truly, that's what they are doing. They are sitting and they are trying to, you know, teach you behavioral, teach you visual imagery, and give you art, and all of those things. That is what they are doing. So usually the word exercise for the mind has helped me. So I would, any other suggestions from anyone, I would be happy to hear.
Madam, good evening.
Yes,
This is
Dr.
Dr.
Pandya.
Sanjay Pandya.
Yeah.
Actually, exactly opposite to this question. I
Mhm.
just wanted to know in a smaller cities where the availability of a psychologist or a psychiatrist is not there,
Hmm.
how do you, as a palliative medicine, can handle the non-pharmacological methods? Like we are not expert on counseling and all those things. So we should insist for that, or should we try enough to control the things?
Okay, thank you so much for that question. So what we do is, see, having said that, what is non-pharmacological? In fact, we've done it in our OPD, and we've also done an audit, and found it very helpful. So what we do is start with routine. Now, it depends on who comes to you. When we are talking of non-pharmacological, what is it that we want? We want at least some amount of exercise that the patient is able to do, or some amount of activity that the patient is able to do. So, and we do not want them to overexert. We do not want them to rest completely, at least in the initial part of the disease and along with disease-directed therapy. So usually I start with, what is your routine? Now, if the patient is a farmer, I tell them, instead of going to the fields the whole day, can you go there for 3 hours in the morning? Can you break your routine and go and do your work for so much time in the morning? And at home, I usually tell patients, do household chores. If the man is at home, then I usually tell them, will you be able to work with your wife and do something in the house? Will you be able to make something? So if we involve them in household chores and we try and tell them to do things in their day without giving them, we can't tell them to go to the gym or go to a rehab center. It may be difficult. And simple breathing exercises like pursed lip breathing is almost mandatory for all our patients. We train them. We sit there and we do it, and we train them. Do pursed lip breathing, because that brings down anxiety, brings down breathlessness. So these tasks, if they can include, if they are manual laborers, what is it that they can do? If that person is sitting on a computer and working all day, can he walk around the house or walk in the area? A little bit of gardening. So these are kind of things that we usually tell them so that it is in sync with their daily activity.
More of a psychological and counseling and all those things I'm more interested,
Yes,
because we are not expert on that.
Yeah.
And psychologists are not available.
So for
So
that,
how do we go for about?
yeah, so it is very personalized, because it will depend on the person in front of you. It will depend on the needs that they have. And like what I said, it's not a one size fits all, because each person has a different coping mechanism. Someone comes and tells you, why did this happen to me? Is distraught, tense. Another person comes and tells you, well, it had to happen. It's my karma. So it is a very different, I mean, that's a hard question to answer, because it comes with it comes with a lot of training, which we have to do. And for this, I think you have to interact also with a psychologist. But the core things that we find helpful are explore concerns. What were you doing before the disease? What are you not able to do now? And try and bridge that. That kind of preserves personhood. So if we work on those two core questions, I think a lot of problems can get, solved.
Okay, thank you.
Sorry. Someone's asked about approach for chronic constipation on patients on chemotherapy. That's a separate session on its own. Are you going to have one, Hashmat?
I think I have to check the schedule. I'm
You
not
might
very
have
sure
to.
about it yet.
So if I have to be really brief and answer that, again, the key to any symptom first is assessment. Assessment of constipation. What was your stool pattern before? What is it now? Stool frequency before, what is it now? Then the second most important question is incomplete evacuation. Are you having incomplete evacuation, or are you able to pass stool completely? Third, keep your Bristol stool chart in front of you. Show it to them and ask them, what is the kind of stool? Is it very hard? Is it like pellets? Is it loose? Is it watery? So you need to know. Now, once you know that, two more things. One, is your therapy causing constipation? Is the disease causing constipation? So if the disease is related to that particular area, that's a different field. I'm not touching on that. Your therapy causing constipation, it is your duty, especially if you give morphine or any opioids or antidepressants, anticonvulsants. Most of these medications, inclusive of chemotherapy medications, cause constipation. So what kind of laxative to choose is also important. So in the practice of palliative care, we usually choose a stimulant laxative because the gut is slowing down completely. So you need a stimulant laxative. Now, bisacodyl will stimulate both the small intestine and the large intestine. Or you use a combination of a stool softener and a stimulant laxative. So that is important. But suppose your patient is in hepatic encephalopathy and constipated, you will choose lactulose. Suppose you have a patient with impacted feces. You can even give polyethylene glycol. That's a good laxative to give, but you should be mindful that your patient is able to drink adequate water. If you give them PEG-MOVE or polyethylene glycol without adequate water, it will not help. So you need to be your laxative has to be written into your analgesic preparation. There is no doubt about that. And I think, oh yeah, you're going to have a session on GI, so you're going to see a lot about constipation there. But it is a very, very important symptom to address.
Madam,
Yes.
something on a non-respiratory symptoms because of the adverse drug reaction of the respiratory medicine, like tremor or a palpitation or something on that.
That's beyond the scope of this session, I think, because tremor and palpitations, first you have to assess the cause of tremors and then the palpitations. And
that as a side effect of the bronchodilator.
Okay, that is something I don't really see much of very often. So maybe I will not be the right person to answer that because I told you I work in a cancer setting. So a lot of my experience is from cancer.
Yeah.
Dealing with those tremors, but that's a good question. Maybe I'll pass it on to Sridevi and have somebody answer it for you.
Okay, thank you.
Yes.
Ma'am, I think we can move with the case presentation as of now since it's 7:32.
Okay. And regarding your question on mechanical ventilation, it's definitely going to be a session because it will be part of what is discussed in either ethics or end of life. So that will be answered, Uttara. That's why I won't take that here.
Thank you, ma'am. We have Dr. Chaitanya for the case presentation today. Welcome, Dr. Chaitanya. You can go ahead. Sangeet, please do the screen sharing from our end.
Okay. Ma'am, is my voice audible?
Yes, Dr. Chaitanya, you are.
Thank you, ma'am. So, I'm Dr. Chaitanya, working as an assistant professor at SWIMS Tirupati. So here I'm going to discuss with you a case of a 45-year-old male patient who was diagnosed with stage 3 non-small cell lung cancer, and with generalized anxiety disorder. The patient came to my OPD 2 weeks back. When I asked him, he had shortness of breath for the past 3 months, and then complaining of cough since 3 months, and then this chest tightness and palpitation since 2 months. A constant feeling of worry and fearfulness was there since 2 months, and he was restless and had difficulty in sleeping for the past 2 months. Coming to history of present illness, the patient developed shortness of breath 3 months back, which was gradual in onset, progressive from grade 1 to grade 3. It was associated with wheeze. There was no history of orthopnea. He had cough since 3 months. It was associated with minimal mucoid sputum, and it was more during the night times. And he had occasional streaky hemoptysis, which was present. He had history of loss of weight and loss of appetite since 3 months, and he had complaining of chest tightness and palpitation since 2 months. And this feeling of worry and fearfulness was there, and he was restless, and he was not able to sleep as well for the past 2 months. He had a history of generalized fatigue, and fatigue, malaise, and some low-grade fever going on for the past 2 months. He was a known smoker who smoked around 20 BDs per day for the past 20 years and stopped smoking for the past 3 months. He was an occasional alcoholic who worked at an agricultural field. He was married and was having 2 children. And patient was diagnosed as having lung cancer 3 months back. Uh, when he was in my OPD, on examination, I could see that the patient was little anxious and was underweight, and then he was pale, and his baseline respiratory rate was around 20 cycles per minute. Heart rate was around 110 beats per minute, and BP was normal. And on respiratory system examination, I could see there was use of accessory muscles of respiration like sternocleidomastoid. And on the palpation, there was decreased chest movements on right side. There was dullness on percussion over the right lower lung field, and on auscultation there was decreased breath sounds over the right lower lung field, and occasional wheeze was heard, and on both the sides of the chest, and bilateral wheeze was heard. And abdomen, it was normal, no organomegaly, and no focal neurological deficits was seen. So coming to blood investigations, next slide, sir. So on complete hemogram was done. It was the HB was found to be 9.5. LFTs, all the parameters were normal. Serum proteins were around 4.5 gram%. And the imaging chest X-ray had a right lower lobe opacity, and CT chest showed a mass in the right lower lobe with a possible lymph node involvement. The size was around 3 into 6 centimeter, and of in the right lower lobe. And the initial PET scan done for metastasis showed there were no metastasis, and biopsy was confirmed. Key, that is a case of adenocarcinoma. So coming to the psychosocial aspects, there were symptoms of anxiety for him, and there were panic attacks more during night. And the patient stopped working for the past 3 months, and the family support system was lacking, and the wife was blaming the disease on his smoking. And he being the sole bread earner of the family, the finances of the family were also affected. And the patient didn't have any prior psychiatric illness. I referred the person to my psychiatrist colleague, who confirmed that the patient was suffering from a generalized anxiety disorder, secondary probably likely to the cancer diagnosis. So oncology people have kept the patient on concurrent chemoradiotherapy regimen. The medications which I offered the patients were inhaled bronchodilators, a long-acting beta-2 agonist, and a long-acting muscarinic agent with formoterol and glycopyrronium, 2 puffs BD with spacer for 2 weeks. And then my psychiatric colleague has advised him on counseling sessions and SSRI, escitalopram, and then clonazepam. It was on propranolol. The other medications which I offered him were multivitamins, and yeah, I offered him pulmonary rehabilitation as well because the patient was constantly breathless, and have advised him for a high protein intake. So the main concern here was his shortness of breath was there, which was which might be because of the COPD or the lung cancer, or maybe because of the anxiety which he was having. And he was worried that his child is due for joining the college, and he has to find some alternative sources of income to financially support his family. And uh, uh, he has been in that social self isolation. I could sense it, and because the moment he heard he was like, what difference is it going to make? Because I am anyways not going to survive with all the treatment or whatever. So even when I was telling him to perform as mere things as like incentive spirometry, he was not convinced, or like it took me a while for him to buy that spirometer as well. So as soon as I told him you need to, I mean the discussion points, as soon as I told him you need to consult a psychiatrist, the first thing is I am well, I am not, what do you call the regular colloquial term? Nakem pichiledu, madam. So that is the regular term which I hear, like whenever I say, the moment I tell you might need a psychiatrist consultation, this is what happens, because I am not, I could sense that the patient was, something was not well in the patient, apart from respiratory thing. But psychoeducation is a important, um, I mean, important important and difficult to deal with in my OPDs is what I feel. It is difficult for me to convince the patients to get a psychiatric consultation, and it is the moment why this respiratory physician is sending me to the psychiatrist or for a consultation. What is wrong? Either sometimes it happens that 10 to 20% of the patient don't turn out to my OPD again. The moment I say like please do consider a psychiatric consultation as well. And then the education about non-pharmacological techniques for relieving anxiety, what could be offered from pulmonologist point of view, if we are the first person who is meeting such a kind of patients. Thank you.
Thank you, Dr. Chaitanya, for that wonderful case presentation. And participants, you can
Okay.
post your comments in the chat box, and based on that, we can proceed with the ma'am will be able to help us on that, and we can proceed with the discussion. She has also added her discussion points here, and if you have any comments, you can post in the chat box.
Yeah, one just one my thought. I just would like to put it over here. Uh, Actually, in these type of cases, I would rather talk to in a way of a psychological counseling rather than psychiatric consultation. So I would prefer rather more of a psychologist than psychiatrist. Psychiatrist only when there is a therapeutic approach is must. But till the behavioral or cognitive therapy, I would prefer to be a psychologist better than the psychiatrist, because psychiatrists, they don't have a time to counsel the patient or have a session. Rather, psychologists are more accustomed to have a sessions and not writing a treatment. So first step, I would be referring a patient to a psychologist rather than and tell them for a psychological counseling, and not the use the word the consultation or a psychiatrist, because there is a stigma related to psychiatrist. So better approach I would prefer like on to the psychologist rather than a psychiatrist.
Uh, Sir, I would leave the decision to my psychiatrist, whether there is a need for medications or whether there is a need for counseling sessions. I don't take the decision for my patient. So we don't have a psychologist in our department and in our institute. We have the psychiatrist. I refer to them, and they take the decision whether the person needs. Yes, they are very good at counseling. At least the psychiatry department at our hospital, they do the counseling sessions as well. So I don't know whether that is the correct approach or not. I won't decide till now. I haven't been deciding whether the patient has to be sent to a psychiatrist or a psychologist. So if there is anybody who can correct me, it will be good. So that decision I will leave for the psychiatrist to take care of, whether he needs the only counseling or counseling plus medications or medications. That I leave it to the psychiatrist for this also. Ma'am,
Okay.
if you can help me with this, like, is it the correct approach? I don't know, but this is what I have been doing.
Vidya ma'am, you're muted.
Yeah. Hello, Chaitanya. That was a very nice case discussion that you did and you presented. You brought out all your, the points that you've done. You've been very thorough with the patient. And honestly, there is nothing right or wrong, okay, in this. So you had a psychiatrist, you referred the patient, that's fine. But I also agree with Dr. Pandya that, see, now I would just like you to think of this person who had nothing till he came. And all of a sudden, he had this diagnosis, he had this financial crisis. And I'm sorry, I didn't get his age. What was his age?
45, ma'am, 45 male.
45. So you're thinking of a 45-year-old man who has been handed over this diagnosis, and you described all his problems, financial, psychosocial, work, self-image, role reversal. He had everything for him, along with breathlessness. Now, because this is one of the most common presentations for lung cancer, usually what we would do in our setup is there one is to explore his concerns, which you have done, and that is how you discovered all this, and that is how you sent this patient to the psychiatrist, which you've done really well. And then you have managed this patient, and I saw your list of medications for this patient. So can you tell me what was the symptom that was troubling this patient the most?
Ma'am, shortness of breath was what he was telling, ma'am. So he was telling both chest tightness.
Yes.
So I was whether that chest tightness has happened because of obstructive airway disease, because of COPD, or was there any underlying anxiety? Was like,
Yes. Yeah, so you're right.
like
He
I
had
couldn't.
everything. He had shortness of breath. So this is the question that we ask in palliative care. What symptom is troubling you the most? It could be anything. It could be I lost my job also. Okay. And gabrahat. Someone has put it. Exactly. So Chaitanya, in your setup, you would say andolam, because Telugu, many of them say gabraga undi, andolam ga undi, gabrahat in Hindi. So this is the symptom they're telling you. Now, if you take a step behind, go back to your model, breathing, thinking, and functioning. So, and look at you described the lung findings. Along with the COPD, there is a huge mass also in his lung. And and one side you have started therapy for the disease. So in our setup, or what we would usually do for this patient is, one is like what Dr. Pandya said, our first step would be psychologist, because within our hospital, we have access to psychologists. We do not have psychiatrists. And even if we had psychiatrists, my first step would still be the psychologist, because he is dealing with a lot of change. Now, if I tell him, go meet a psychiatrist, and like what he exactly told you, nakem pitcha, that could trouble him even more. So first level psychologist, next level psychiatrist would be would be a nicer thing, because from the patient's perspective. And more importantly, this patient would have really benefited with a low dose of morphine, because in lung cancer, when they present with breathlessness and cough, I think you also mentioned cough, low dose morphine works beautifully. It just brings down the symptoms so well that then the patient's trust builds. He starts feeling better. The minute he starts breathing better, he starts feeling better. And what we usually do is the oncologist starts with the therapy. We start with low dose morphine, say 2.5 milligram. I start with 6 hourly, and then put them on a 10 milligram SR dosing, OD dosing. That nicely takes care of the symptoms. Once the symptom burden is down and we give pain, we give paracetamol. And then we start with the non-pharmacological. You asked me what could be the non-pharmacological for the anxiety and for the breathlessness. So if we look at non-pharmacology for breathlessness and anxiety, few things are very, very useful. One is paced activity. That is, you sit down and tell them, take good laxatives. Make sure you don't strain when you pass motion. Make sure what you eat is soft. Because once you have to chew, you start getting breathless. So what you eat is soft, you pass motion properly, you pace your activity. We are not telling you to quit your job. We are only telling you to pace your activity. Take rest interim and do it. And then teach them pursed lip breathing. It is the most beautiful exercise to bring down both anxiety and breathlessness. So you breathe in once, you take out as a long breath, you demonstrate pursed lip breathing and do it with them and tell them to practice it. And a handheld fan. If the patient is very breathless, handheld fan has as much evidence as oxygen. So we get that on Amazon. We in fact distribute it to our patients in the hospital if they can't afford it. So you hold a handheld fan 10 centimeters from your face, it hits the trigeminal nerve, it works like oxygen, makes the patient feel better. Now, once the breathlessness comes down, the stressor that my disease is getting addressed with oncology comes down. These are the things that I would bring up as a palliative care physician. I would tell them, see, we are working on bringing down this symptom. Once you start taking treatment, your symptom is going to come down. And then gradually, I will bring down your morphine also. Now, we will also give you some exercises which will make you feel better, which will make you less anxious, which will comfort you. And that's how we send the referral to the psychologist. And when you do all of this, half the symptoms are down. And then you send them to the psychologist. I mean, this is the usual thing that we do. But having said that, if our patients are not responding to this, if they are still anxious, getting panic attacks, then definitely psychiatry intervention and maybe medication. But the most important thing is the follow-up. Because what happens is if we don't follow up, they take these medications lifelong and they get them over the counter. That is what we need to avoid. So that is why use your non-pharmacological to the maximum. And another thing is spirometry can be very difficult for a patient with only COPD. Now add cancer to that and then put his mental health here, spirometry will become difficult. So first, pursed lip breathing. Next round, when symptoms get better, then start the spirometry. So, if we try and go step by step, it actually works well. So I don't know if it helped you, but these are, you did really well for your patient. And I'm so happy to see so much of your history and everything, which has already been taken. So maybe if you can, tweak your, add morphine a little earlier in care, it really, really helps these patients.
Thank you, ma'am.
Participants, if you have any more questions, you can post in the chat box. There was one question regarding can we prescribe morphine by ourselves? So Dr. Adasha, I have posted a link and you can click on that and we have all the guidelines for stocking and dispensing ANDs in medical institutions. I think that helps and I have commented on the same there. It will help you.
Chaitanya, you're from SWIMS, right?
Yes, ma'am.
Yeah, so you'll
Yes,
have
ma'am.
access. I think you'll have a
Yes,
have
ma'am.
a palliative care unit also and
Yes, ma'am. We have, ma'am. We
Right.
have. So radiation oncology. We
Yeah,
have a
yeah.
well.
Very
But the
nice.
thing is, I don't
Yeah.
prescribe morphine by myself, ma'am.
Yeah,
The oncologist.
But just work with your oncologist. Try it. It works so
Yes, ma'am.
well in lung cancers that
Yes,
initially,
ma'am.
after that, you can nicely taper it off. When treatment starts working, no, you can taper the morphine. And again, you can start
Okay.
when they need it.
Okay. Thank you.
You're welcome. Somebody has asked, steroids we usually give for an exacerbation. What dose are we giving for fatigue? So in a cancer setting, patient has severe fatigue, we use what is called as pulse doses of steroids. So we give them a 4 milligram OD dose, and for 3 days, 2 milligram OD for 3 days, taper and stop. So basically 1 week. So many centers have different ways of doing it. Some hospitals do it thrice in a week. Some hospitals, like we do it once in a month, say 1 week in a month, we give the steroid and then taper it off. So this is for patients when it really helps them overcome fatigue. It's not like a dictum to give it, but when we see the symptom, we give it. And it works very nicely for them. All right. So I think, Hashmat, if we are done, we can call it a day.
Yes, ma'am. Yes. Ma'am, there's one more question. Do you use anabolic steroids from Uttara Vijay and Pooja Bajaj has
We
completed?
usually use dexamethasone. That's the steroid that we use. We use corticosteroids. And yeah, we use dexamethasone most commonly in our setup. And that's what we use in most cancer centers. Almost always, actually.
Thank you so much, everyone. Thank you so much, Vidya ma'am and Dr. Chaitanya for bringing in a wonderful case for
Yeah.
presentation. Thanks a lot for joining us today, ma'am, for such a wonderful session. Over to you, Sangeet.
And Chaitanya, you're welcome to join. We have VTBs. I don't know if there's anyone from Andhra Pradesh. SWIMS also takes part in the virtual tumor boards in palliative care. We hold it on, the last Tuesday of every month. So it would be lovely if you could present and bring in your experiences also.
Yes, ma'am. I'll definitely
Yeah.
take.
So they are
Actually,
good.
this was
No, I'm
this
so happy
program
to
was.
see you present, from the respiratory side.
Oh,
They're really, really nice. And so please join into the
thank you.
VTBs also. Yeah. Dr.
Thank
Pranavan
you.
Das will be there. You can coordinate with him.
Yes, ma'am. I'll speak to him. Thank you, ma'am.
Very nice. And all the rest of you whose faces I cannot see, thank you, Dr. Pandya, for keeping your video on. It's nice to see at least one face when you're taking a session.
Thank you, madam. It was a nice lecture.
Thank you. And bye, Hashmat, and bye, everyone.
Thank you so
Thank you,
much.
ma'am.
Yeah.
Thank you
so
for the
much,
wonderful
ma'am. Bye-bye.
session.
Yeah.
Thank you,
Bye.
Dr. Hashmat, for facilitating the sessions. Thank
Yeah.
you all for participating actively. Thank you, Dr. Chaitanya, for the wonderful case presentation.
Yeah.
Thank you all. Let's see you in the next sessions. Thank you. Bye.